Good afternoon. For those who weren't in the previous section, hello, I'm Tim Cook. I'm an anaesthetist and intensivist in Bath. I'm not part of PUMA, but I'm part of the PUMA guideline writing group for the unrecognised esophageal intubation guidelines. And I'm going to talk about what I describe as the anatomy of unrecognised esophageal intubation. I have no conflicts of significant importance. Those are they. I think there are two sorts of typical airway disaster. This is the first one, which is, I think, the commonest sort of airway disaster, and it's usually an issue of perseveration or repeated efforts to establish an airway without transitioning through an appropriate algorithm, usually leading to failed intubation, failed oxygenation, ventilation, and front of neck airway, which is often unsuccessful. However, I think the anatomy of death by unrecognised esophageal intubation is rather different, and rather than a problem of repetition, it's a problem of omission. So it usually starts with a simple error. Is this in the trachea? Is it not in the trachea? You tell me. And these are the features that I'm going to describe. I think they're common to most events, and I will go through them once I've described a few cases. This is Martin Bromley, writing more than a decade ago at the start of NAP4, sitting around a coffee room table, anaesthetists will tell me how they wouldn't have behaved in the way the anaesthetist did in my late wife's case. It's incomprehensible. But place those same anaesthetists and colleagues into a simulator a week later, you'll be surprised how many do follow the same path when presented with the same stresses and human factors. I think this applies to now as much as it did more than a decade ago. So if we go back to NAP4 and its credible data, I'm not sure of better data in terms of incidence. We disappointingly found that 5% of the cases reported in NAP4 were unrecognised esophageal intubation, all leading to significant harm, including 6 deaths, 1 brain damage, and 2 prolonged stays on ITU, probably with other permanent harm. If you look at the denominators, that gives a rough incidence in anaesthesia of 1 in a million cases, in ITU 1 in 15,000 intubations, and the emergency department 1 in 10,000. Who knows how that's changed? And this was a typical case from NAP4, a patient with a known history of asthma and latex sensitivity, with planned elective surgery, no airway assessment, unclear planning. Anaesthesia was started. This was soon followed by difficult mask ventilation, hypoxia and cardiac arrest ensued. This was assumed to be anaphylaxis. And tracheal intubation at that time was hampered by a moderately difficult grade 3 laryngeal view. The capnograph trace was flat afterwards, and this was ascribed to loss of cardiac output. Ventilation remained difficult, ascribed to anaphylaxis and bronchospasm, and no action was taken to actively exclude intubation. As time went on, eventually there was a decision to re-intubate. This was successful, but profound hypoxia occurred for a long period of time, leading to permanent vegetative state from hypoxic brain injury afterwards. A more recent case from 2020, Glenda Logsdale, which has been prominent, particularly in the UK, but not the most recent, a case of fatality from unrecognised esophageal intubation. We learned both from the inquest and also from the coroners trying to tell us how we must respond and learn. Of course, we must not forget no trace or poor trace, wrong place until actively excluded. And capnography is the mainstay of our diagnosis. In this case, one of the individuals in the in the room misidentified the airway pressure trace as a capnograph, and therefore thought that there was CO2 being produced, although in fact this was absent. In the coroner's report, it described the clinicians, particularly the index clinician, being fixated on a diagnosis of anaphylaxis and not being able to move on from that. This fixation being translated to other individuals and a failure to go back to the basics of ABC, which might have led to removal of the tube at an earlier stage. The coroner commented that the individual was not acting in an arrogant or dismissive manner. This does not necessarily happen. It does not happen to bad people. It happens to good people. They described chaos in the anaesthetic room, a large number of people, a lack of leadership, and a loss of situational awareness. And the index anaesthetist said, as often says in these cases, it never occurred to me that I could have made such a grave error. Another case from the UK, Sharon, who died after elective surgery and difficulties with reintubation after a laryngeal polypectomy. Again, from her prevention of future deaths statements from the coroners, they described a large number of individuals, 4 consultants, 2 other doctors, trained theatre staff, failure to appreciate capnography signs, a lack of coordination, lack of situational awareness, a lack of senior experience in a crisis situation. And after the inquest, the Trust Chief Executive said lessons have been learned, would be widely shared with the staff involved, and that procedures have been changed, implementation. Simulation training has been given to the staff, and the family, as it were, on the footsteps of the coroner's court, grieved, but emphasised most importantly, they did not want to see it happen to other individuals. Another case, Peter, whose case happened the same year as Sharon's case. This occurred after, during a knee operation, there was a need for urgent intubation after LMA failure, regurgitation and unrecognised esophageal intubation, leading to hypoxia and failure to recognise that the flat trace did not, in fact, mean that was due to cardiac arrest. As in many cases, multiple times, the ODP stated, could this be in the esophagus? And that was not acted on until too late. Stephen Powis, writing after the event, said there was an over-reliance on clinical signs over monitoring equipment. So auscultation, etc., believing that that breathing sounds were normal. And it's not a problem just in the UK. Yes, there are problems in the UK. They've gone on for some time, but in pretty much every country you look for it, you can find it. And we have a list on the Puma website of at least 30 of these cases, several from Australasia, several recent. And the more you dig, the more you find. These are hidden cases. They are hidden in the soft literature. They're hidden in the media, and they're hidden in other places. Perhaps the most recent in Australia, a 19-month-old in New South Wales, a very tragic case. And these are complex cases. The flat trace wrong place is an oversimplification, as Andy will describe. It is often poor trace may indicate wrong place, not simply wrong, not simply no trace. And yet, if we look globally, this is from the InTube study published in JAMA last year, only 25% of critically ill patients in this international study had capnography at the time of intubation. I can tell you, if that was the rate at the time of intubation, the rate subsequent to intubation will be significantly lower. And there was a rate of 6% of esophageal intubation, with 2/3 of those not having capnography at the time of esophageal intubation. This is unacceptable. So as it happens, this is not in the trachea, this is in the esophagus. And that's the first step that happens in what I call the anatomy of esophageal intubation. So an intubation which is often easy, which could be with direct laryngoscopy, occasionally with video laryngoscopy, is mistaken for having occurred correctly. There is a flat or a poor stroke inadequate capnograph, and this is explained by the intubator for other reasons. So there is a fixation error that actually everything's okay, and there's a problem with the capnograph, or actually all is good. And there's what I call, so there's this anchoring bias to another cause for the flat capnograph, often intubation being caused, the flat capnograph being caused by anaphylaxis or bronchospasm, which are probably not inadequate causes for a truly flat capnograph. And there's this, as I say, what I call exception fixation. There's a special reason on this case why the capnograph is flat. This simple error then progresses to a clinical crisis. There's usually only a couple of people present at the time that the error occurs, but when the crisis occurs, there is soon many more people come in. So there may be a failure to revert to the basics, and the algorithm, which Andy speaks about, tells us very clearly that we should be thinking about taking that tube out unless there is a life-threatening reason not to. If there is not adequate sustained exhaled carbon dioxide, we should take the tube out unless there's an overwhelming reason to. And there is an over-reliance on clinical signs, which I will talk about later. So there's a call for help, and many, many people come and deal with this crisis. Usually this happens at or around the time of cardiac arrest, and the individual who's intubated the patient will explain that they've seen the tube going through the cords, they know the tube's in the right place, they've listened, and others will listen and hear the same. Cardiac arrest has usually occurred at this time, and we carry on with this exception fixation. Yes, I know about esophageal intubation, but this isn't. We must press on. Crowds are difficult to manage in these circumstances. Coroners sometimes talk about a lack of leadership, but sometimes there is leadership, but the leadership takes the individuals who arrive in the wrong place. Maybe there is a role for someone to stand at the end of bed like a trauma leader and say, I need to stand back and see what's happening here. If you're anesthetizing in an anesthetic room, I don't think anybody should be these days routinely, there's often a lack of space. There's too many people, there's noise, there's chaos, there's difficulty. Usually the diagnosis is considered, whether it is verbalized, as it is in many cases, so the diagnosis of esophageal intubation is considered, whether by one of the anesthetists, the airway managers, or by another individual is variable, but it's often considered well before the tube is removed and reinserted. And there's this over-reliance on history of easy or successful intubation. I saw it go through the cords. And an absence of a structured response. And if anything, the Puma algorithm gives the opportunity for a structured response, both in terms of actions, but also considering other causes of an inadequate capnograph trace. There is a loss of situational awareness. There is chaos. And when finally it is decided to remove the tube, usually airway management after that is straightforward, whether it be by mask ventilation, insertion of supraglottic airway, or reintubation. And critically, it's usually not the individual who intubates in the first place who makes the decision to reintubate. Death ensues, usually several days later on critical care. There's time to consider the events that happened. There is usually a local apology, local policy changes, and local training, which are all announced significantly at the coroner's court, saying we must learn from this locally. And there may be local or national investigations which may inform and I hope things will improve. And the family at the foot of the coroner's court say they don't want this to happen to others. The aim of the Puma guidelines is to see if we can ensure that this does not happen to others, or that it happens less and less frequently. So we've learned from NAP4, when previously perhaps we thought that the difficult airway was predominantly anatomical, that airways can be difficult anatomically, physiologically, logistically. You're in the wrong place, you haven't got the right tools, you're pre-hospital, et cetera, or educationally, you're inexperienced, or you haven't been educated in all the tools that you could or potentially should be using. And most of the death and harm, I believe, comes from the non-anatomical difficulty, physiological difficulty accounting for cardiovascular collapse, but logistical and educational difficulty accounting for a lot of harm. It is all about human factors. The life of each patient with an artificial airway is entirely dependent on our actions and attention. We do have the tools to eliminate undetected esophageal intubation. And as a profession, we can and must do better. Thank you very much.